Hi everyone, on behalf of GU Oncology Now, I'm Brian Rini. I'm the Chief of Clinical Trials at Vanderbilt University. I'm pleased to be joined today by an expert panel of kidney cancer experts, and we're going to talk about really the spectrum of therapy for frontline kidney cancer, from observation and drugs, and also some of the new data, including triplets and what will be coming out in the next year. So I'm going to have each panel member introduce themselves, and we'll start with you, Dr. Ornstein.
Hi, I'm Dr. Moshe Ornstein. I'm a GU medical oncologist at the Cleveland Clinic, where I spearhead the RCC efforts.
Hi, I'm Shuchi Gulati. I'm an assistant professor at UC Davis Comprehensive Cancer Center. I'm really excited to be here.
Monty Pal. I run the kidney cancer program at City of Hope in Los Angeles.
Great, thanks all for being here. So what about triplets? Moshe, start with you. Merck has a big triplet study ongoing. There's some others sort of being planned. Are they all going to follow the same path of, man, they're really hard to get and marginal benefit, or not?
So, some of the question revolves around, can you give the triplets safely from a toxicity perspective? And whether cabo ipi-nivo was the right triplet. But let's say, for Merck's trial where you're doing lenvatinib and pembrolizumab and their anti-CTLA-4, is there's something different about that triplet where you can have the appropriate drug delivery to really see the benefit up front and the potential for survival benefit. So I wouldn't close the door on the triplets yet. I think this triplet combination of cabo, ipi-nivo wasn't the right one because of the toxicity. But I think if we can figure out a way to get, so far everything we've seen in kidney cancer is more is better up front, up until cosmic for the most part, right? The doublets are superior to the single agents. And if you're taking two different mechanisms that have at least potential synergy, I think we should try it and see if we can get it right from a safety perspective.
Shuchi, what do you think?
Yeah, I just want to add, I think when we start designing these triplet trials, we probably need to start thinking about biomarkers. I know we are really behind in the biomarker space, but is there a biological rationale to combine these drugs? Or are you just adding toxicity by combining everything together? Yeah. So I think it's time for us as a group to start thinking about biological rationales behind combining these drugs, not just throw everything together and give it to.
Yeah, because I totally agree with you. It's just not how drug development tends to proceed.
But I know in a dream as a junior investigator, I can think.
I'm 100% supportive.
And for that reason, the OPTIC trial is really good, even though we still don't know what to do with some groups in that categorization. But maybe some data from trials like OPTIC will add to our understanding of, this is the group that needs the triplet and this will not benefit. So I think we need to start working towards that. And I know we all are, but.
Yeah, I agree. We haven't even talked about biomarkers because we don't have any clinically actionable biomarkers. Exactly. PD-1 is unreliable, and there's things that are investigated, and we certainly all agree, right, is that some sort of risk-adapted approach based on biomarkers. There are patients who can get, as we said, nivo or pembro monotherapy and do really well. Exactly. Right? We have no way how to identify them. There's probably others that need a triplet of whatever different mechanisms.
And we don't know who those patients are. It's certainly not the poor risk patients based on the Cosmic 313 data.
They probably need other mechanisms,
exactly.
is my sense, and not the ones we have. But we don't have those biomarkers. So in the meantime, we'll just keep cramming drugs together. I mean, I agree with Moshe. I mean, I think the Merck trial is different. It also has belzutifan in it. We can maybe touch on belzutifan in a second. So it's some different mechanisms. But I think we learned, and maybe you said this, Monty, just to cram everything together, that's not going to work. And we're going to have to be more thoughtful, whether it's patient selection or staggered approach or dosing or, I don't know, I'm sure there's other strategies, different mechanisms. But I think we will get to a place where triplets are standard. I'd be shocked if all these trials are, and we're sitting here in 10 years with doublets. I just don't. Yeah. And maybe it's drugs that haven't entered the arena yet in terms of that third drug.